Thank you, sir. Uh, Good afternoon, all of you. Thanks, Diabetica and RSSD Gujarat chapter, to giving me opportunity. In fact, in between the lectures of the patrons and my teachers. So thank you so much. My topic. There are two topics involved, and after Rumandrav sir's comment that we have not still defined these whether it is a disease or not, we are having the treatment of that. We have going to discuss complications and we are going to treat the targets, right? So I have something else to tell, and I would humbly differ from him that it is not a disease. It is a time for us to accept it as a disease, which people already have. I don't have any financial disclosures for this talk. So my flow will be in four part: problem statement, complications of obesity, targets of weight loss, and take home messages. Why problem statement is important is, as the first talk has to be kept, still there is dilemma and confusion that should be put obesity as a disease or not. The definitions are there, but remember the word by AAC, the American College of Endocrinology, that ABCD concept, that is adiposity based chronic disease, right? Adipose tissue are the biggest endocrine organ in the body, and the disease related to that is still debatable in country of India, that should we declare this as a disease or it is just a risk factor. Obesity has multifactorial origin and it is very complex process to understand, and that is why perhaps there are issues in understanding about this, but perhaps this is an elephant in the room we are not able to recognize. Already 2012, 13 years before, AAC position statement was that it is a designated disease, and since then it is not changed. 2013 only, American Medical Association already has accepted obesity as a disease, and I believe that looking to the burden of the disease and the benefits of treatment in a justified patient in a clinical obesity, we must declare this as a disease and a huge challenge also, because the classification of the obesity cannot be same for the Caucasians and Indians. What Caucasians have decided, class 1, 2, 3, 4, we all know from the textbook, cannot stand safe for the India. The epidemiology worldwide, even though India is not extremely overburdened, now the data from the India says that it is increasing. Hence, now, this is very important slide. It looks very simple, but previous 2016 stage of obesity were improved. This is not a classification of obesity. The classification is 1, 2, 3, 4, where BMI was 35, 30 or more than 40. But this is stage, which is a complication-based classification of the obesity. So the treatment of obesity is for the clinical obesity, where you look out forward for the complications. Hence, to discuss the complication is very important from this platform. The stages have been increased from 0, 1, 2. Now to 1, 2 and 3, that stands for no complications, 2 stands for mild to moderate complications of obesity, and 3, that is a stage 3, is at least one severe complications. We all know the YY paradox. The YY word comes from the two scientists, one from India, Dr. Yazrid sir, we have heard many times, and Dr. J.S. Yudkin sir. This is very famous picture published in Lancet in 2004, and same BMI, two different people, but the fat composition is almost more than double for the Indian. So Indians cannot have the Caucasians classification, because being a thin fat Indians, we have more abdominal fat, more insulin resistance, high CRP, and so many derangements. Hence, if I have to put everything in a one paper, the Caucasian guidelines, the AAC ADA guidelines versus the Endocrine Society of India Asia Pacific guidelines, which are now accepted by all the bodies across India, is this. So if you compare this obesity classification, overweight to obesity class 1, 2 and 3 with staging, which is actually a complication from 1, 2 and 3. So for the BMI of India, specific classification is 23 to 25 perhaps is overweight, 25 to 30 is class 1, 30 to 35 BMI is class 2, and more than 35 is class 3. And this is very important for us to understand, because without that, targets of weight loss and medications or pharmacological treatment or a surgical treatment cannot be given. Now, with these notions, the complications of obesity to be understood is very, very important, because they are the drivers to decide what class the patient is, what stage the patient is, what medicines, pharmacological therapy or surgical intervention has to be opted for. Whenever there is a dysregulation between the energy intake and output, there is an obesity which occurs. So whenever the excess fat is there, it will get accumulated into the different places of intra-abdominal, liver, or epicardial and muscle, ultimately will lead to inflammatory states inside this organ, and there might be end-organ complications at the heart. For there could be myocardial infarction, aortic stenosis, and failures. For the kidney, CKD, lungs, COPD, and sleep apneas. For the vessels, it could be PVD, and for the brain, cognitive dysfunctions and stroke, and ultimately can lead to death. So this is just one of the pragmatic illustration of how from normal weight to the increasing weight, if it is associated with the adiposity based inflammation, that can get converted to clinically significant complications of obesity, and there can lead to end organ damage. Do we have evidence that increasing the obesity has lead to a lot of complications? Yes, they are published many years before, and still they are on publications. Diabetes, hypertension, and dyslipidemia are on higher side across various publications. On higher BMI, higher the diabetes, dyslipidemia. Coronary artery disease are also on higher side whenever has been published that they are on higher side with the high BMI people. Mortality are also associated with it, and then hence I recommend all of you that consider obesity as a disease. This is the association between BMI and all-cause mortality. Even malnutrition doesn't mean obese person. Malnutrition also means a less BMI people. At the extreme, it is a U-shaped relationship. So lower the BMI, more likely to be dying from the malnutrition. Higher the BMI, also likelihood that they might end up with the bad disease. So obesity actually is a multi-system disease. It is not one endocrine organ, but a lot of organs which are involved as part of the etiology and complications as well. So there could be neurological, pulmonary, renal, genitourinary, musculoskeletal, psychological, cardiovascular, gastrointestinal. In fact, if you remember the COVID time, there were guidelines saying that patients with diabetes or coronary artery disease or patients with obesity are likely to have more risk factors, which is now endorsed by every guideline. What organ-specific complications can occur in obesity? So which I have tried to pull the analysis on these. That as far as liver is concerned, if you have an increasing overweight to class 1 BMI, class 2 and class 3 BMI, there would be fatty liver to steatosis, to NASH, to cirrhosis and hepatocellular carcinoma. Cardiovascular complications, pre-hypertension to hypertension, left ventricular hypertrophy, coronary artery disease, post-MI, congestive heart failure and death. From metabolic part, insulin resistance to pre-diabetes to type 2 diabetes and over complications. From sleep part, snoring, mild OSA, moderate OSA to severe OSA. Neurological part could be devastating for cognitive and strokes. As far as joint are concerned, fatigue, osteoarthritis, severe ON immobility. I could have added lines and lines of these for complications, but the time is less. Just one part which needs to understood is, as far as if I give an example of liver, the MSLD term is now more important rather than NAFLD, which says that hepatic complications are also one of the part of obesity and ongoing metabolic risk issues. From healthy liver, there are 15 to 30% people who would turn to steatosis, then steatosis, inflammation and ballooning, which is NASH, to cirrhosis and sometimes hepatocellular carcinoma. In fact, there is a common soil theory which says that nearly 50% of type 2 diabetic patients or more than that in India having obesity. So whether the mother or the baby is whom is difficult to predict in this scenario. Hence, the term which is coined now by ACE is, the American Heart Association also says that it should be considered jointly cardiovascular kidney metabolic, that is CKM syndrome, which is a recent term coined for this, which includes type 2 diabetes, obesity, dyslipidemia, hypertension, CKD and cardiovascular system involvement as well. There are stagings which are defined for CKM syndrome, and I believe that CKM syndrome defines the all issue in a very nice way, from stage 0 of risk factors to up to stage 4 of clinical and over post-event patients. Now, this is very important slides of today's talk. I understood that there are trials showing weight loss benefit, some trials on sugar benefit, but if you see the many trials like look ahead, they have failed to show absolute advantage. So just doing weight management is not going to help the patient. Secondly, ACCORD, ADVANCE and so many clinical trials have also shown that just merely controlling the sugar, being a glucocentric is not going to help your patient for end organ benefit. If you want to make your patient live longer, healthier and better lifestyle, it should be holistic approach, and various clinical trials have shown Steno2, SOL, EMPA-REG, DEPA-HF, DEPA-CKD, LEADER, REWIND and SUSTAIN 6 and so on. The goal is ultimately to control all 4 basic pillars which AD has also endorsed, that control your patient's weight, control your patient's blood pressure, control patients' sugar, control patients' basic risk factors. That's all is required as a holistic approach, which have shown in many clinical trials. And in fact, it has shown us in ADA recommendations also that practice-changing guidelines have been observed for last 10 years. So the goal of management of the obesity complications is driven by complication itself, should be blood pressure reduction, weight reduction, decline in renal health, and decrease in cardiovascular events. Now, I hope that you would accept that obesity is a worrisome thing and the complications are one which are the driver to decide for the target of the weight loss. For those patients, if you need to understand, the target of weight loss has to be very specific, measurable, achievable, relevant, and time bound, which is called as a SMART goal for the weight loss. So put a conclusion on the slide. If type 2 diabetes is there, 5 to 15% of weight loss can give you a reduction in the HbA1c and decrease medications if possible for diabetes. For your patients of metabolic syndrome, you require to have a 7 to 10% weight loss. For dyslipidemia, 5 to 15%. For hypertension, 5 to 50%. For methyl, 7 to 10%. For PCOS, 5 to 50%. For sleep apnea, 7 to 11%. So these are the targets which you can specify for your patients for the weight loss with obesity. Now, do we have any means to do so? We were discussing in the past, no, but now do we have means? Yes, we do have means. The complex intervention of different receptors in the body, the brain, the gut has been identified like MC4R receptor, lipase, GLP-1, leptin, adipose tissues. There are site of obesity medications which are defined now, which has given us power to benefit it. So, if the puzzle of what is harming more is solved by CKM, what is the ultimate answer of CKM puzzle? The initiator like metabolic dysfunction, the amplifier like CKD, and the outcome like cardiovascular disease, who will give us the best answer for everything altogether. That is the solution of CKD syndrome. Perhaps GLP-1 receptor agonist is one of the very promising molecule which can give us all the benefits, because GLP-1 have shown cardio protection, renal protection, blood vessel protection, atherosclerotic plaque, myocardium, and central nervous system benefits as well. They are also a weight reducing medications and beneficial for sugar control as well. Beneficial actions of GLP-1 has been proven by vascular system also in different trials by direct and indirect effects. Particularly the semaglutide has shown in SOUL trial recently launched has got label indication that now you can go for these prescription for your patients who have high cardiovascular or CKM syndrome. Now, how this benefit translates in the terms of benefit of your patients. Say, for example, if patients with a NASH or hepatic fibrosis comes to you, weight loss target should be 5, 7, and 10% by resolution of NASH could be 10, 26, and 64% respectively. For fibrosis, it could be 45, 38, and 50%, and steatosis improvement could be on higher side. But the unfortunate part is that only 70% of patients can achieve 5%. A lot of patients can achieve 5%, but to achieve 10% of weight loss clinically in your OPD is very difficult, which is only 9% in the real world data. So, but as far as GLP-1 receptor agonists are concerned, they are one of the mainstay of target of weight loss where they can achieve everything, and they have been endorsed by various clinical guidelines, 2024 EASD, ESL guidelines, KIGO guidelines, ESC 2023, ADA and ESD all have endorsed GLP-1 as one of the very key factors in prescribing your patients with obesity. Do we have any means to achieve these targets? So I'm not going to discuss about the treatment. The next speaker, Navneet sir, is going to talk about it. I'm here to just make you focused on what are the target of weight loss which can be achieved to benefit your patients for various diseases of obesity complications. So it could be phentermine, orally state, so 3 to up to 20%. One of the highest perhaps is tirzepatide, which is available in India now. Another comparison as far as the GLP-1 agonist I have created, a lot of trials I have just compiled on one plate. Sorry for the busy slide, but at one page I wanted to deliver that you can have a correlation of every drugs available right now in India or not available. As we all know that lexasenatide, exenatide are a bit old drugs. Dulaglutide, I don't see much prescription nowadays, but Lira is available and off patent now. Semaglutide, we have oral tablet available, but which has label indication for diabetics only. Please don't consider your patients that you lose weight with this as an official indication, because the label indication is for diabetes management only. But the good news is that it is likely that by month of July, perhaps India is going to have a Wegovy as a brand of semaglutide injectable, which is officially approved for patients of diabetes as well as non-diabetics also. And tirzepatide is already launched just few days back. And believe me that every clinician, perhaps or diabetologist, would have noise level in their chamber that at least in my practice, I have patients coming to the inquiring that I need to these medication for weight loss. So tirzepatide is available not as a brand name of Zepbound, which is approved in USA for weight loss, but at least as a Mounjaro, which is approved as an official label indication for diabetes and obesity. But yes, as an off-label, the same molecule can be used for the obesity patients also. So if I want to summarize entire spectrum into one slide, this is what I can do. Sorry for the busy slide, but if I have to put every classes on one slide, this is what I could do best, right? So it is starting from the overweight to the obesity class 1 with staging 1 and 2, obesity class 2 with stage 2, obesity class 3 with stage 3, what BMI range of AAC, what BMI range of the India specific guidelines, what weight loss should be targeted, like you can remember the word 5, 10, 15 and 20% for all the classes, and treatment aspects are based on these complications and target are also from there. Just one last slide is pending. So lifestyle and pharmacotherapy, but lifestyle is recommended for overweight patients. Pharmacotherapy can start with the obesity class 1. Obesity class 2, you could have metabolic surgery if you have target organ damage. And class 3, definitely you should have a higher GLP-1 like tirzepatide, or if co-associated retain possible, bariatric surgery could also be one of the leading cause, perhaps sleeve, gastrostomy and ruin valve. Dr. Navaria sir will explain us more. So the final slide is for the take-home message, and these are very important for us to understand. Please accept obesity now as a disease as world has already accepted it. It is a chronic and multifactorial in nature. It is adipose tissue dysfunction, and genetics and behavior are a lot of things are influenced by it. But we need to keep in mind that the main drivers of obesity complications are actually the main driver of the treatment decisions, right? And please remember the YY paradox. We cannot adopt the Western Caucasians parameters for us, so we should have Indian specific, which we already have. And we need to have a comprehensive approach. We should not treat the patients just for the weight or just for the sugar. It should be all together, which will make him more important as far as the end of the life is concerned. There will be prevention of the loss of mortality and mobility. Thank you so much.